So now we proceed to thank you again, Dr. Faiz, for the informative sharing. And now we proceed to Dr. Ramzuzaman Ismail. He's a consultant emergency and currently an emergency physician at Hospital Raja Permaisuri Bainon Ipoh. He is also active in publication related with emergency and trauma. With the title Update in Sepsis, please welcome Dr. Ramzuzaman Ismail. I'm sorry again, guys. We have some technical issue. All right. Okay, so, all right. Okay, doctor.
Okay, we start again. Assalamualaikum warahmatullahi wabarakatuh and very good morning. So today I will present a bit on the sepsis update. Well, sepsis is actually a big topic and also very controversial. There's so many things that is going on at the moment. Next slide, please. Next slide. So in the 2016, the sepsis surviving sepsis campaign has published their latest guidelines, whereby the definition has been changed, and there are some things that has been opt out, and some of the things bringing in. So the sepsis definition has changed to a life-threatening organ dysfunction caused by a dysregulated host response to infection. So the keyword is a life-threatening organ dysfunction and dysregulated host response. That means whenever a patient is being infected by something, the patient's own body response become dysregulated, and it will start to cause organ dysfunction. So, and the other thing is the definition of septic shock. Now it is considered to be a patient who is in septic shock, who needs vasopressin and lactate more than 2. Previously, it was lactate more than 4. So now they take lactate more than 2, and the patient needs vasopressin, patient is hypotensive. So that is septic shock. And previous from the 2012, there is a definition for severe sepsis, but now since 2016, severe sepsis is out. No more definition, no more condition classified as severe sepsis. And now we are using the SIRS since many decades ago. SIRS, severe inflammatory response syndrome. We know that SIRS caused by a lot of things, not only by infection. Even you exercise a bit, that will lead to SIRS. Yeah. So SIRS is very, very non-specific. So that's why they bring in the qSOFA and SOFA. qSOFA is a quick sequential organ function assessment. So this qSOFA and SOFA are used to screen the patients who is potentially to have sepsis, septic shock. Okay, next slide. But there are a few problems. Yeah? So before we go into the problems, I just want to illustrate the difference between the old and the new sepsis guideline. So in the old sepsis guideline, there is SIRS with suspected infection. That is old guideline. But in the new guideline, if you have a patient who you suspect or documented to have infection, plus the patient have 2 or 3 on the qSOFA, which is the qSOFA has 3 elements: hypotension, altered mental status, and tachypnea. Hypotension means systolic blood pressure less than 90. Altered mental status, ECS, is 13 or less, and tachypnea, respiratory rate more than 22. Okay, or if you have SOFA score raised by 2 or more. But SOFA score is a bit more complicated. We need more parameters. So it has been suggested that we use qSOFA, which only has 3 parameters in the emergency department. Now, in the previous guideline, there's if you have this findings of systolic blood pressure, lactate more than 2, systolic blood pressure less than 90, MAP less than 65, INR more than 1.5, and so on and so forth, together with sepsis, that is severe sepsis. But it has been now in the new guidelines, this severe sepsis has been taken out. So now in the septic shock, the previous guideline, this is the sepsis plus hypotension after adequate fluid resuscitation. But now we have to consider septic shock is sepsis with the need of vasopressors to maintain the MAP more than 65, plus the lactate is more than 2 after adequate fluid resuscitation. The next slide. So this is a qSOFA. You can see that there are only 3 parameters that we need to assess: the blood pressure, the mental status, and the respiratory rate. Okay, and if the score is 2 or more, it suggests that this patient has poor outcome. So if the patient is considered to be sepsis, you suspect that the patient is having sepsis, and having 2 out of these 3 parameters, that is going to be considered as sepsis. Yeah, so you have to arrange the patient to be managed as sepsis. But next slide. This is SOFA score, the sequential or sepsis-related organ failure assessment SOFA score. This SOFA score has a lot more parameters. The respiration, in terms of respiration, we need to have the PF ratio, whereby we need the ABG as well as the oxygen saturation. And you have to need some lab parameters in terms of the coagulation, the platelets, the liver function, renal function. So it takes time for us to get these parameters and score the SOFA score. Right, so it is not really useful as initial screening method in the recognition of the sepsis, but it's more useful, especially in the ICU. So if the SOFA score is 2 or more, that is, and the patient having sepsis, so that is an indicator that the patient has a poorer prognosis. So the mortality rate can be up to 20 to 30%. Next slide. Next slide. So the surviving sepsis campaign has suggests that this is the way that we use the SOFA and qSOFA. So if you have a patient who you suspect to have an infection, you will do the qSOFA, looking at the is there any blood pressure less than 100, respiratory rate more than 22, and is there any evidence of altered mental status? Okay, if the patient has 2 or more of this criteria, and you suspect that this patient has sepsis, so you have to assess for evidence of organ dysfunction. So that's why we use the qSOFA. qSOFA is a method to assess the evidence of organ dysfunction. So if there is, then the patient is having sepsis. So we have to manage the patient. And if the patient, after given some fluids, then you still see that the patient is still having hypotension, needs some vasopressors to maintain the MAP more than 65, and withdraw the serum lactate is more than 2, then the patient is having septic shock. Okay, but I will illustrate to you there's a bit of problem in terms of using this algorithm and in the recognition of the sepsis, especially in the emergency department. Next slide. Okay, in the 2018, an update by the Surviving Sepsis Campaign has been published to suggest that we do everything in 1 hour. So initially, in the 2016, whatever that we have to do, whatever the targets that we have to achieve, it has been mandated to be achieved in 3 hours, and some of the parameters can be achieved after 6 hours, within 6 hours, sorry. But in the 2018, everything, every parameters, every goals has been shifted to be achieved, try to be initiated within 1 hour, especially in the emergency department. That is because some studies has shown that if there is a delay in the management of the sepsis or septic shock patient, there will be some increase in the mortality. For example, in this study, antibiotics delay and the antibiotics delay will lead to increase in mortality. However, we have a few problems in trying to do everything in 1 hour, especially in the emergency department. As you know, the emergency department does not only cater for patient who is having sepsis or septic shock, but we also cater for other patients. So in this study, it shows that we still cannot achieve the targets within 1 hour. Even if we achieve, the mortality also does not make any big difference. Okay? So as you can see, this study is being done in one hospital, whereby there is a pre-intervention and post-intervention. The pre-intervention means that the hospital is doing whatever management as previous, and the post-intervention, they introduce some of the protocols to make sure that the diagnosis of sepsis, the antibiotics, and so on and so forth, is being tried to be done within 1 hour. But as we can see that the mortality in terms of the patient who have, in terms of improvement of the mortality, it does not make any big difference. Okay, so we have to think whether should we do everything, try to do everything in 1 hour, but what is the benefits? What are the benefits to the patients in terms? Is it useful or is it not? Because there's a lot of resources that we need to put in order to target everything to be achieved within 1 hour. Okay, next slide. Okay, so I've discussed a bit, I'm going to discuss a bit on the usage of SIRS, qSOFA, and score, new score. Because many studies have found that qSOFA is not really sensitive to screen to be used as a screening method to screen sepsis or septic shock patients, especially in the emergency department. In this study, they compare the scores SIRS, qSOFA, and new score, basically to look at the ability of these scores to get the diagnosis of severe sepsis, inclusive of septic shock. And then they look at the secondary endpoints, whereby to look at whether these scores can identify the patient who has severe sepsis, septic shock, or any sepsis, and sepsis-related in-hospital mortality. Next slide. So what these studies have found that the qSOFA score is having very poor receiving operating characteristic for the primary and secondary outcomes, and the new score has outperformed SIRS and qSOFA in all aspects. Okay, so it is a receiving operator characteristic, actually looking at the performance of the score or performance of a test. If the test achieve the score of ROC is 1, that is very good. Nearer 1 is good, but if the score is nearer to 0.5, is useless. Okay, so you can look at the new score. The performance of a new score is almost near to 1, okay, in all aspects, in the identification of severe sepsis, septic shock, and also predicting the sepsis-related mortality. Okay, next slides. Next slides. Okay, in the previous slides, it shows the overall performance of the SIRS, qSOFA, and new score. But in this slide, it shows that if you get the cutoff, use the cutoff. If you're using the cutoff, so the ROC is not really important. But then again, if you look at the cutoff, SIRS, qSOFA, and news, so again, we see that the new score outperform SIRS and qSOFA. Okay, so we can see that here, qSOFA has, with a cutoff of 2 or more, it has very high specificity, but the sensitivity is very low. So in order to use something to screen, we need a test that has high sensitivity. So we see that the qSOFA is not really useful to be used in the emergency department to identify the patients, to screen the patients that come to the emergency department. So that is why I advocate we use the new score. Okay, it has high sensitivity, and specificity is also not too bad. Okay, next slide. Next slide. Okay, so new score has a few parameters, but these parameters actually you can get from the at the site. It doesn't have any investigation parameters. Whatever that we need can be obtained from the bedside. Actually, these parameters are the usual parameters that we use to get in all patients, especially at triage. Go back. Especially at the triage and also during the monitoring of the patient. Okay. So, so it has the parameters of respiratory rate, SpO2, the oxygen supplement or systolic blood pressure, the pulse, consciousness, and temperature. So if this is a score, okay. So, for example, if the patient having a respiratory rate is more than 25 or more, it's called 3, and so on and so forth. You can see this SpO2 scale 1 and scale 2. So most patients, we are going to use the scale 1. Okay, if you're using NEWS2 score, we are using scale 1. Okay, scale 2 is only for the patient who is known to have hypercapnic respiratory failure. Okay, if you know this patient has previous admission or in this current admission, you can see that the patient is having hypercapnic respiratory failure. PaCO2 is high and patient is having a respiratory failure. We are using the scale 2. Okay, but even though the patient having, for example, chronic obstructive airway disease, COED, we should still use scale 1. Okay, COED patients still should be used scale 1 unless they are documented to have hypercapnic respiratory failure. Okay, I know this is a lot of things to remember, yeah, but don't worry, actually this is available, easily available, yeah. Okay, next slide. So how to use this NEWS2 score? If you think if you have a patient and you do the NEWS2 score 5 or more, you think about sepsis. Okay, so in a patient who has NEWS2 of 5 or more and a known infection, signs and symptoms of infection, or maybe the patient is at risk of infection, you have to think, could this be a sepsis? And then escalate care immediately. Okay, next slide. Next slide. Actually, you don't have to remember previous slides. Previous slides. Okay, so you don't have to remember everything in the NEWS2 score. You can get this medical calculator. You can download into your phone. You can get these apps from the App Store or Google Play, and after that you just key in whatever the parameters that you have obtained from the patient, and then the score will be auto-calculated for you. So don't have to remember everything. Yeah. Okay, next slide. So this is a proposed usage of the how to use this new score. So if you have an elevated new score, I believe that in emergency department, hospital Raja Permai Sri Bainun, we are trying to implement the usage of a News 2 score to be integrated in the HIS at KKM. We can use this new score integrated. So if you have a new score, News 2 score, if any of the parameters is 3, or the News 2 the parameter score, composite score is 5, so you have to triage the patient to at least yellow zone and escalate the treatment. Yeah? Then if you think this patient is having sepsis, then this patient has to be triaged into the red zone. So if you have the patient and then news score more than 5, you have to alert the physician, alert the doctors, then ask the doctors to review the patient and then treat accordingly. Okay. Next slide. Next slide. Next slide. Go to the next slide. Okay, this is the one bundle published by Surviving Sepsis Campaign in 2018, whereby, of course, we know that the sepsis or septic shock is a medical emergency, and they recommend that we initiate bundle of these bundles to be initiated within 1 hour, especially in the emergency department. But the 1 hour is from the triage itself, from the triage. Okay, so once the patient comes in, and then you have to do the initial screening, and if you think that this patient is having sepsis, then the patient has to have this bundle within 1 hour. So of course, the issue that we have encountered, I have discussed some of them earlier. So the one bundle, initial resuscitation for the sepsis and septic shock, we have to measure lactate, obtain the blood cultures before the antibiotics, then give the antibiotics, broad spectrum antibiotics, then begin rapid administration of 30 ml per kilogram crystalloid for hypotension, or if the lactate is lactate more than 4. And then apply vasopressors if patient hypotensive during or after fluid resuscitation to maintain the MAP more than 65. And then remeasure the lactate if initial lactate elevated. Okay, I will illustrate to you the challenge, the problem that you might encounter in order to get this bundle within 1 hour. Okay, next slide. Next slide. Okay, next slide. Okay, basically we're going to, I will try to illustrate to you the challenges that we have in terms of implementation of the our one bundle of surviving sepsis campaign. There are basically the 6 challenges. So challenge 1, the definition of sepsis that I have discussed earlier, whereby the surviving sepsis campaign advocates to use the qSOFA, but there are some problems with it, especially in the screening of patients in the emergency department. So I think it is better to use news to score to screen the patients who are having sepsis. Challenge 2, the bundle compliance and protocolized sepsis care. Challenge 3, the time zero. The time zero and emergency medicine. Challenge 4, the lactate. Challenge 5, fluids, and challenge 6, timing of antibiotics. Okay, next slide. We go into this one by one. Yes, next slide, yeah. Okay, in terms of the bundle compliance and protocolized sepsis care, many studies have shown that protocolized sepsis care does not really improve mortality. The 3 major trials, the ARISE, the PROMISE, and the PROCESS trials have shown that comparing the protocolized sepsis care with the usual care is just actually the same. It doesn't matter as long as the patients are identified early, given IV fluids early, given antibiotics early, then whatever pathway that we use after that, either early goal-directed therapy, either is it protocolized or the usual care, actually is less important in management and that resuscitation. So it means that it doesn't make any sense to force anybody to do things according to the protocolized care, as long as whatever needs to be done is being done. Okay? You have to identify the patient, of course. You have to identify the patient as early as possible. You give the fluids as early as possible, if the patient needs the fluids, and give antibiotics early. And if you do all that, these studies have shown that there's no difference. Either you use the protocolized care or the usual care. Okay. Next slide. The challenge 3, the time zero and the emergency department. The surviving sepsis campaign mandate, the time zero is actually at the time of triage. That the time start to tick. But the problem is more than half of patients that eventually have sepsis or severe sepsis, septic shock, does not really demonstrate the evidence of sepsis upon presentation at the triage. Okay, so we have a problem if we start everything at the triage, 0 hour at the triage. So it means that we have to get every single patient that come to triage must go to the somewhere, especially in the red zone, in order to screen either they are having sepsis or not. So that is not possible, right? So then that's why we think that the time zero should not be the time of the triage. The time zero should be the time of physician suspicion of infection. Okay. That is the time when we start to make the diagnosis of sepsis or septic shock. Then whatever the bundles that we need to do within 1 hour should start there, not at the time of triage. Okay. Okay, the next slide. The next slide. Challenge 4 is lactate. Of course, there are evidence that elevated lactates are associated with increased mortality. And there's also evidence that lactate clearance is associated with lower mortality. But we never know the exact lactate level that should trigger the aggressive resuscitative effort. The Surviving Sepsis campaign has mandated that lactates more than 2. But this lactate more than 2, there's not much of evidence to say that is the exact lactate level that we should use in order to trigger the resuscitation, use the bundle. Yeah. Then there's also a study, Andromeda Shock trial, showing that we don't have to use lactate in order to monitor the patient's resuscitation. We can actually use the peripheral perfusion by looking at the capillary refill time to see whether the patient is adequate or inadequately resuscitated. Okay, this interesting study comparing the capillary refill time and the lactate clearance. It shows that there is no difference in terms of the patient's mortality. So instead of keep on repeating lactate, we can actually use the capillary refill time. Okay, and if you see that the capillary refill time is more than 3 seconds, that means the patient is poorly perfused, and we need to do something about it and continue or escalate our resuscitation. Okay, so in this way, by monitoring the CRT, it is good enough rather than measuring the lactate. Okay, next slide. Okay, the fluids. The Surviving Sepsis campaign has mandated that every patient who has been diagnosed to have sepsis must have fluid resuscitation at least 30 mL per kilogram. And this has to be initiated within 1 hour. Okay, but we know that aggressive fluid resuscitation and positive fluid balances are harmful and can increase the mortality. Mortality in many studies have been shown that is related to positive fluid balance. So rather than giving every single patient who's having sepsis or septic shock 30 mL per kilogram, we think that the patient should, the fluid management should be individualized. Okay, so we have to see the patient's fluid responsiveness and also fluid tolerance. And if the patient needs the fluids, of course, we have to give, and not to give even a drop more. Okay, okay, next slides. Okay, about the timing of antibiotics. In the Surviving Sepsis campaign, they have advocate that antibiotics should be given within 1 hour, and we have to take the blood CNS before the before the antibiotic administration. But this target of 1 hour of antibiotics administration is not really evidence-based. In fact, there are many studies that shown that there's no significant survival. For example, in this study, there's no impact in terms of the mortality. Either you give 1 hour or 3 hours of the septic shock recognition. Okay, and there's another studies comparing the administration of antibiotics in the ambulance itself and antibiotics given in the emergency department as the usual care. And this study have shown there's no difference in terms of 20-day or 90-day mortality between sepsis or severe sepsis or septic shock patients who receive antibiotics in the ambulance en route to the hospital versus the patient who has been given antibiotics in the emergency department. So, so it means that the timing of antibiotics within 1 hour is not really evidence-based. Yeah? And if we rush to give antibiotics, we might, if we rush giving antibiotics to every patient that we think potentially having sepsis or septic shock, so we are going to lead to antibiotics overuse. Yeah? And also, as we know, antibiotics overuse is not really something that we because it leads to antibiotics resistance. Yeah. So the antibiotics within 1 hour is really not really useful. It's not really evidence-based. So we think that antibiotics, yes, we need to give antibiotics as early as possible. Once we recognize the patient is having sepsis or septic shock, yeah, but not necessarily rush things. Yeah? Give antibiotics just in order to get to the protocol within 1 hour. Okay, next slides. So that's why there's some petition to retire the surviving sepsis campaign. Next slides. So that's why we suggest that there's some suggestion. There's some things that we need to change in this surviving sepsis campaign bundle. So the proposed revised statement, we suggest that these bundles should be initiated within 1 hour of physician suspicion of infection causing hypotension or lactate greater than 4 millimole per liter, and fluid bolus of 30 ml per kilogram should be administered to patients when it is safe to administer such a volume. Okay, so it's not really everybody. Okay, we have to use the clinical judgment and manage the patient. Okay, next slides. So whatever has been said, we all agree that previous slides. Whatever has been said, we all agree that the sepsis or septic shock is one of the medical emergencies. So the fundamental treatment goals is in the sepsis or septic shock is early recognition, early source control, early antibiotics, and a fluid resuscitation still holds. Yeah? But we don't really agree that whatever the surviving sepsis campaign advocates to be done within 1 hour for every single patient. So we have to use the clinical judgment and try to individualize the treatment for the patients. Okay, with that, I end the presentation. If you have any questions, I will happily answer them in the chats. Thank you.
Okay, thank you, Dr. Ramzuzaman, for the interesting sharing on sepsis. So, for everyone, we will take a break for 5 minutes, and we will come back around 11:20.